Hi, today we'll learn about myofibroblasts and why it's important for plastic surgeons. Myofibroblasts are specialized fibroblasts. Fibroblasts we know are the most abundant cell in the connective tissue, which are derived from mesenchymal stem cells and produce extracellular matrix. Now the myo component of myofibroblast is more specifically smooth muscle component, which is present in two forms. One, cytoplasmic microfilament bundles. Here bundle term is important because cortical cytoplasmic meshwork is present in fibroblast also. The second form is alpha smooth muscle actin, which can be remembered by the mnemonic AA. Here alpha term is important because beta and gamma actins are present in fibroblasts also. These two together form stress fibers, which provide myofibroblasts their characteristic contractile property. So myofibroblasts were first described in 1971 by Gabbiani while studying granulation tissue. He's from Italy and works in University of Geneva. He also described that the myofibroblasts work as syncytium through gap junctions like smooth muscle, and the presence of alpha smooth muscle actin grossly increases its contractile property. Now this is important. Fibroblast, which is somewhat spindle shaped with cortical, that is peripherally arranged cytoplasmic actin, on mechanical tension, which may be gaping of a cut wound, transforms into proto-myofibroblast, which still have the cortical actin, but then also has cytoplasmic actin bundles, which we see here, and extracellular fibronectin fibrils. So in presence of soluble factors like transforming growth factor beta-1, extra-domain A fibronectin, and other inflammatory cytokines, in addition to the mechanical tension, they transform further into differentiated myofibroblasts, which usually are stellate shaped and have additional alpha smooth muscle actin, which is depicted in pink here. So it amplifies the contractile force of the myofibroblast. Now the intracytoplasmic actin is in continuity with the fibrils extracellularly through adhesion complex, which is a transmembrane integrin called fibronexus. Now the extracellular fibrils are in contact with the extracellular matrix. So now when the myofibroblast contracts, it also synthesizes new extracellular matrix and eventually leads to extracellular remodeling, which is nothing but the extracellular matrix becoming more rigid. This further increases the mechanical tension in the microenvironment around the myofibroblast and thus gives rise to positive mechanical feedback cycle. This continues till the extracellular mechanico-chemical factors resolve, which may be due to wound healing, suturing, or cover with flap or graft, due to which the myofibroblast goes into the apoptotic phase and reverts back to its fibroblast form. Myofibroblast, especially the dermal ones, have three physiological roles. First one is wound healing, second is inflammation, and third is organogenesis. As plastic surgeons, we are primarily concerned with wound healing. Myofibroblasts are present in all the three phases of wound healing, appears on day 3 and stays till 10 to 21 days. Its main job is wound contraction and wound remodeling. Now by healing, it's not just skin wounds, but also the healing of bone, cartilage, and tendon, where it helps in the formation of stable scar or callus. Some examples in plastic surgery where myofibroblast plays a role: the secondary contraction in split or full thickness skin graft, twice lesser for full thickness. Please follow the links below for more details. Non-operative forms of facial rejuvenation where skin tightening is obtained using laser or chemical peel or dermabrasion, etc. and distraction osteogenesis. Other than the dermal fibroblasts which we saw, cells with the myofibroblastic function are present in various organs like the hepatic sinusoidal cells, lung septa, renal, bone marrow, fibrocytes. Even the epithelial and endothelial cells can transition into myofibroblasts either during development or in tumorigenesis. Pericytes, which are cells around the microvasculature in various organs, play a central role in transformation into myofibroblasts in various organs. Pathologically, with relevance to plastic surgery, again, it plays an important role in hypertrophic scar and contractures following various wounds including burns, where instead of undergoing apoptosis, it persists beyond 10 to 21 days, sometimes for months, in the granulation tissue, causing excessive fibrosis and contracture. It plays a role in Dupuytren's contracture, joint stiffness by involving the synovial cells, breast implant by involving the stromal cells, and neuroma, where the surrounding scar contracts and forces the regenerating nerves to sprout outwardly. Other than that, it causes fibrosis in all the organs which I described earlier, has a role in cardiac infarct, atheroma, restenosis, plays an important role in the pathogenesis of sclerofibrotic diseases in the body, and helps in the invasion and metastasis of epithelial tumors. Though there are no anti-fibrotic therapeutic agents currently that may prevent myofibroblast hyperactivity, attempts have been made to target progenitor cells like pericytes which transform into myofibroblast, or else change the extracellular mechanico or chemical factors by inhibiting the intracytoplasmic actin, which is the contractile element, by inhibiting cell-to-cell transmission through cap junctions, by inhibiting extracellular matrix remodeling or rigidity, and by promoting the apoptosis of myofibroblast. As of now, the only effective strategy, for example, against hypertrophic scar, has been by modulating the mechanical and chemical factors. For example, by closing or suturing the wound early, by early excision or debridement and cover with skin graft or flap, or else by compression using pressure garments.
Here's how we can draw a simple line diagram of myofibroblast for exams. Visit the links below for all references. Thanks for watching. For more such videos, like, subscribe and hit the bell button.